and welcome to your lecture on hypertensive disorders in pregnancy. So these are the learning objectives that we're going to cover for the various hypertensive disorders. So we're going to look at the differences between gestational hypertension, preeclampsia, eclampsia, chronic hypertension, superimposed preeclampsia, and HELLP syndrome. We're going to discuss preconception, antepartum, intrapartum, and postpartum management of the woman with chronic hypertension. Describe etiologic theories and pathophysiology of preeclampsia. Compare care management of women with preeclampsia with or without severe features. Describe appropriate nursing actions during and after eclamptic seizure. We're first going to talk about chronic hypertension. Okay, so these disorders precede pregnancy, but diagnosis can be difficult due to undiagnosed hypertension. So up to 30% of women may present in pregnancy with a pre-existing hypertensive disorder. So we differentiate this because we know it occurs prior to the 20th week of gestation. Common pregnancy complications, so we know it complicates about 5 to 10% of all pregnancies, and that number is probably increasing. There is an increased rate in mothers age 40 or greater, nearly 10 times higher than mothers younger than age 20. And we know that women are having babies later on in life due to careers. Increased risk for preterm delivery and fetal growth restriction. And this is just due to the fact that all pregnant women with hypertensive disorder, regardless of severity, are going to be delivered by 37 weeks. So really meaning that if the patient stays stable long enough to reach 37 weeks, they will be delivered no later than that. Fetal growth restriction is common because we will talk about the pathophysiology of how it restricts the growth in the fetus. There is a strong correlation between chronic hypertension and cardiovascular disease risk. And this is significant because older women in their 50s and 60s are developing cardiovascular disease that had a history of preeclampsia. So chronic hypertension in pregnant women. So we know obesity rates are increasing among women, and this is contributing to the problem. Women over 30 are having children. As I said earlier, it's increasing. And then you think about in terms of pregnancy and complications, women in their mid-30s are having more complications. 90% of women with chronic hypertension also have primary hypertension. So really what this means is that this is the only thing going on. They don't have an underlying medical condition that's contributing to the hypertension, which is also referred to secondary, which may be caused by renal or endocrine disorders. So it is associated with the increased incidence of placental abruption. Remember, we talked about this. This is really important for you to remember for testing purposes. This is one of the number one causes, or probably I should say the number one cause of placental abruption. And we're talking about really high blood pressures. So we're talking about severe range blood pressures, 160s over 110s. Increased perinatal mortality. And this is just due to the fact there's a lot of early deliveries and that women are sick with this condition. Preterm birth, as I mentioned earlier, all women with hypertensive disorders will be delivered by 37 weeks. IUFD, intrauterine fetal demise, 2.3-fold increased risk, especially if other comorbid conditions exist like diabetes or cardiovascular disease. These infants are often small for gestational age. Postpartum complications include pulmonary edema, renal failure, heart failure, encephalopathy, cardiovascular disease. And the higher the blood pressure, the higher the risk, along with a higher risk of kidney disease. Because we know that long-standing hypertension or untreated hypertension is associated with more comorbidities. Target organ damage does occur. This affects the brain, kidneys, and heart, and it is more common with the development of superimposed preeclampsia, which we're going to talk about next. Okay, superimposed preeclampsia is a development of preeclampsia in women with chronic hypertension. So really what you're looking at is you have a pregnant patient, they present after the 20th week, they have a blood pressure of 140 over 90, either or, it can be systolic or diastolic, and then now they may develop other things. So with chronic hypertension, this is really all they have, is high blood pressure. They don't really have any other conditions going on. Like they're not spilling a lot of protein, they have fairly normal lab values and such, but all they have is chronic hypertension. When we're talking about superimposed preeclampsia, this is where they're developing other symptoms. So in 40% of women who have chronic hypertension, superimposed preeclampsia occurs. It's much worse prognosis for the mother and the fetus should she develop this, because again, you're adding insult to injury when they already have chronic hypertension. It's diagnosed by new onset of proteinuria after the 20th week. If they had proteinuria prior to the 20th week, they may have sudden increase in blood pressure, needing increased dose on meds. So let's just say they were controlled really well on antihypertensive medications, and their blood pressure, we brought it down to 130s over 80s, okay, which is good, fine if if they have chronic hypertension. But let's just say now it's creeping up to the 140s over 90s despite the medication. So now we know there's a problem going on. So there is a substantial increase in proteinuria. And really it's greater than 3 grams in 24 hours or 300 on a protein creatinine ratio. That's really all we care about. We used to define in terms of severity of proteinuria, and now it's just a standard greater than 3 grams in 24 hours or 300 on protein creatinine ratio. So make a note of that. I do have to change this slide because they did change that. Renal insufficiency, so creatinine greater than 1.1 milligrams per deciliter or doubling in serum level. We know they're in renal failure. Thrombocytopenia, platelet count less than 100,000. Sudden signs and symptoms including headache, epigastric pain, visual changes. Now these are all indications of preeclampsia with severe features. Pulmonary edema. So how do we manage chronic hypertension? So we're going to do vital signs, deep tender reflexes, clonus. Clonus is where we have the patient relax their leg, relax their foot, and we roll their ankle in a circular motion and we push back on the ball of their foot. Now if we get like an involuntary reflex against our hand, that's known as clonus, and then we measure it in beats of clonus. So they may have 1 or 2. This just indicates increased level of cerebral edema and irritation. So we know if we have brisk reflexes and clonus, our patient is more likely to seize or have a seizure. We're going to measure INOs because again, we're worried about renal failure. Level of consciousness. Like I said, there's more cerebral edema and more swelling in the brain. And so with this condition, especially if they deteriorate and become severe, they may have this level of consciousness alterations. We don't give any ACE inhibitors or ARBs in pregnancy. Absolutely contraindicated because it causes birth defects. It affects namely the fetal kidney growth development. So if they are on an ACE inhibitor, which we use very commonly to put people on blood pressure management, or ARBs, we're going to be switching that medication to either labetalol or Procardia XL. Okay, so these are the medications we use to manage chronic hypertension in pregnancy. Antihypertensive medication administration is indicated if they reach a blood pressure greater than 160 over 110. Now this is severe range blood pressures. These blood pressures are always treated with IV push medication, or we're going to be giving them oral nifedipine to lower the blood pressure. There's a whole antihypertensive protocol that we follow when a patient presents with these blood pressures, and we're going to talk about that coming up. Most already on an oral form of antihypertensive medication. Again, that's going to be in the form of Procardia XL or labetalol, PO. Effective medications, now these are the ones we use, IV push, or we're going to use nifedipine orally for hypertensive emergency. Okay, so this is hydralazine, labetalol, and nifedipine. You need to know the names of these medications. You don't have to know dosages, but you do have to know the names. Monitor for worsening condition, so labs. Are their labs turning bad? Do they have more symptoms? Is their blood pressure increasing despite medication? Fetal surveillance is indicated at 28 weeks, as well as growth ultrasounds, because we're worried about growth restriction in these babies. Gestational hypertension. This is a different type. So now you're looking at an onset of hypertension after the 20th week without protein in the urine, and you're not going to have anything else. Basically, what happens is these patients are over 20 weeks and they have a systolic blood pressure of greater than or equal to 140 or diastolic blood pressure greater than or equal to 90. Most frequent cause of hypertension in pregnancy. And typically what you're going to see is these patients are going to have slightly elevated diastolic. That's usually what we see. So we're going to see things like blood pressures 120s over 90s, okay? But they don't have anything else going on. We send them over to L&D for a workup. Labs look good. Their blood pressure sometimes will go down, and they may have a couple that are in this range. But the key is they need to have two blood pressures at least 4 hours apart, of greater than over 140 or greater than or equal to 90. Okay, so that's the diagnosis really for gestational hypertension. The incidence, okay, so it's most common after 37 weeks. And that's the good news, is we need to deliver these patients, again, because they're hypertensive. But we got pretty much good lung maturity in the fetus to be able to deliver by that time. So very rarely do they have issues of prematurity, but they can. Okay, it can still occur. Incidence in 2 to 4% of prima gravidas, 6 to 17% in multiparous mothers, and it's elevated blood pressure that does not any elevated blood pressure that does not resolve postpartum leads to the diagnosis of chronic hypertension. So very, very important for these patients to follow up postpartum, especially if they have hypertension, because we want to make sure that it went back to normal. Women should be monitored for signs of preeclampsia. So we will most definitely be watching these patients a lot more closely. We're going to be dipping their urine, checking for protein, performing deep tendon reflex checks, and monitoring for any symptoms they may develop, because this is the only way that we're going to know the patient is evolving into preeclampsia. If they're getting sicker, we need them to be able to tell us. Another thing that they need to do, and this is probably coming up on a slide, but they need to monitor their own blood pressures at home, and they need to report any elevation in blood pressure. So women with gestational hypertension generally don't need to be medicated with oral medications. Usually their pressures aren't really high enough to need that. But if they are, we may put them on it. But we don't want to bottom these patients out either on their blood pressure, because we can cause hypoperfusion to the placenta and further deteriorate growth development in the fetus. So preeclampsia. So this is another separate disorder. So this is hypertension and proteinuria that develop after the 20th week gestation. Complications are approximately 3 to 7% of all pregnancies. But again, this number is probably increasing. They go into multi-organ system involvement, manifests mostly in the second half of pregnancy. And again, this is the good news, because we're past that viability stage in the newborn. So we do try to get as much out of the pregnancy as we can without mom getting really sick. So most of them, we may be able to give steroids, boost lung maturity, and then deliver the patient. We try to get as much maturity out of the fetus as we can. Classified into preeclampsia alone or preeclampsia with severe features. So this is subcategorized based on blood pressure readings and symptoms. Okay, so let's talk a minute about the pathophysiology. So it is thought to originate from abnormal implantation of the placenta. And this occurs early in the pregnancy. So the interesting thing about this is it does set up early in the pregnancy, but it doesn't manifest until later. Okay, so we're not seeing the implications of this until later in the pregnancy. So essentially, trophoblast invasion in the superficial decidua failed to achieve conversion from small, high-resistant vessels to dilated, low-resistance vessels, which normally leads to increased placental circulation. And you can see that diagram on the right is showing you how narrow those vessels are. And this is occurring at every single blood vessel in the placenta. And you can see on the left how the blood flow is more open and much more easier to reach the baby, okay, through placental circulation. So placenta ischemia leads to production of placental factors entering maternal circulation, causing widespread endothelial dysfunction. Placental factors, these inflammatory and anti-angiogenic, antagonize placental growth. So the exact cause remains unknown. So we don't know what predisposes some women to this and others do not get it. But we do think there is a genetic factor. If there's a first-degree relative that had preeclampsia, mother, sister, someone like that, you may think those women are at higher risk. And this does have a generally high recurrence rate. So when we think about placental ischemia, think about these narrowing blood vessels, less oxygen, less blood supply. And then this causes damage to the vessels. So it also causes damage in the mom's blood vessels. So if you think about endothelial damage and then dysfunction, and what happens is these blood vessels get damaged, they start leaking. So they're leaking fluid into the extravascular area. This is what causes edema. And when you have leakage of the blood vessels and any kind of damage to blood vessels, that's where you get platelet aggregation. Platelets go to the site, they attempt to repair the blood vessel, and this is what leads to platelet consumption. And that's where you get that low platelets. Okay, so this is a spectrum disease. So it can be a very mild form where they don't go that far as having that damage, or it can be very, very severe where we're talking about HELLP syndrome, which we're going to talk about coming up. All right, so diagnostic criteria. So hypertension with persistent elevation of either blood pressure of greater or equal to 140 or diastolic of greater or equal to 90 on 2 separate occasions, at least 4 hours apart. And that's going to define your hypertension right there, just hypertension alone. Now, if you're throwing in other things, you've got proteinuria. And as I mentioned earlier, this is now greater than 300 milligrams per deciliter in 24-hour urine specimen, or a protein creatinine ratio of 0.3 milligrams per deciliter. So a dipstick reading of 1+ may also be used in the absence of a quantifiable testing. So this may be used like in an office setting, but generally they're going to be sent to the hospital for a workup. Okay, then they're going to run that protein creatinine ratio. Now, a 24-hour urine specimen is going to be way more accurate than a protein creatinine ratio because you're collecting urine over time. So you're seeing what it's doing over time. Whereas a protein creatinine ratio is a very quick way to figure out, okay, they have proteinuria. And we use that because if we need to be able to make a decision on what we're doing due to a mom's high blood pressure, we're going to use that. And if we don't have time to do a 24-hour urine, because keep in mind, delivery is the cure for this. So if you have someone presenting with really high blood pressure and really bad labs, they're not going to stick around very long. They're going to get delivered because delivery is the cure. Proteinuria is not required to meet the diagnosis. This used to be the case. It's not anymore. So some women may not spill protein at all. They may spill a little bit of protein, but it's not significant enough to be constituted as proteinuria. So if they don't have proteinuria, the other criteria that can also meet the diagnosis includes thrombocytopenia, greater than 100,000 on the platelets, impaired liver function, so usually elevated LFTs, AST, ALT twice the baseline value. So typically with these liver enzymes, they're going to be quite high. They're not just going to be mildly elevated. You may see that, but then, it's not really telltale, but a lot of these women, we don't know their baseline unless we've been monitoring it. Like if they have chronic hypertension or gestational, we're going to be monitoring labs. Okay, at least every week, if not more than that. So they do have a new onset of renal insufficiency. We're going to see a creatinine greater than 1.1 or the doubling of serum, pulmonary edema, and you know your patient is really ill if they have pulmonary edema at this point. Onset of cerebral symptoms, headache or visual disturbances, which now they're venturing more into the severe range. Okay, so let's talk about risk factors. So we know that there's no exact cause for this, but we know there are certain things that put women at risk for preeclampsia. So preeclampsia in the prior pregnancy, primiparity, so first baby, obesity, chronic hypertension, multifetal gestation, you have more placental tissue when you have multiples, thrombophilias, so things like lupus, diabetes type 1 and 2, family history of preeclampsia, renal disease, maternal age over 40 or 35 with comorbid conditions. All right, so let's talk about nursing assessment. We want to identify and prevent preeclampsia. So is there a way to prevent this? There didn't used to be until studies came out showing baby aspirin, 81 milligrams, starting at the 12th week of pregnancy, was linking women to lower incidences of preeclampsia, especially recurrence. Okay, so baby aspirin is an effective way to help either make the disease milder or maybe to avoid the disease. Not all women will get preeclampsia with their next pregnancy, but a lot of them will just because they have the predisposition. Also, I'll throw that in there, but having a different father of the baby, so a different partner, sometimes they'll develop preeclampsia with that partner, and then they'll have a new partner and they won't. So they think that that may play a role as well. So goal of therapy, so we want to ensure maternal safety and delivery of a healthy newborn close to term. And that's what we're doing here is we're weighing out the risks and benefits mostly to the mom. Okay, there may be fetal factors. I mean, if you have a severely growth restricted fetus, that's going to be reflected in placental blood flow as well as umbilical artery Doppler blood flows, which we're watching. Okay, so they're also known as UA Dopplers. So we know the flow through the umbilical cord can be problematic in some of these fetuses with growth restriction. So we're constantly watching this, okay, along with doing labs. These babies are getting ultrasounds pretty regularly. I would say at least every couple of weeks, especially depending on severity. Okay, so that's what we're looking at with that. Assessment diagnostics, so pitting edema, deep tendon reflexes. Now let me go back to edema. Not all women with edema have preeclampsia. Okay, that used to kind of be a criteria, but not anymore. If you have a patient with normal blood pressure, but they have edema, it's not a concern until they develop hypertension. DTRs and clonus, I explained kind of what clonus is before. A chem panel with LFTs, BUN, creatinine. Now, what I'll say about the BUN is a BUN over 5 in pregnancy is abnormal, okay? It's not a diagnostic marker for preeclampsia, but it is something we look at because it is an indication of kidney function. Now, lactate dehydrogenase, this is not something we're going to order routinely, but if you have a patient with preeclampsia with severe features or HELLP syndrome, we're going to be looking at that LDH because what it tells us is outcomes. There's generally poorer outcomes with moms with an elevated LDH for her and the baby. Okay, so we're looking at numbers of greater than 600 on that. CBC and platelets. Okay, some women on the H&H are a little hemoconcentrated, but we're also looking at platelet count. Uric acid over 5 milligrams per deciliter is abnormal in pregnancy. And sometimes what we'll do is we'll run a set of labs. Someone has elevated blood pressure. We'll run a set of labs. And what happens is they'll have an elevated uric acid. And so although it's not a marker, it does give us indication. And it does tell us it's coming. They're probably more than likely going to get preeclamptic. Okay, so that's a good marker to have. And this is not a lab that we do like on a serial basis, not like CBC and CMP. and then urine for protein. Okay, so we're going to be checking for that. All right, so a question for you: which of the following patient presentations indicates a possible preeclampsia? Patient's 29 years old, at 18 weeks gestation, presenting with proteinuria and a blood pressure 150/90. Patient is a 32-year-old at 28 weeks gestation, presenting with proteinuria and a blood pressure 145/90. Patient is a 28-year-old at 28 weeks gestation, presenting with blood pressure 150/88. Complaint of headache and no protein in the urine. Okay, so when you're looking at all these, what you're looking at is you're looking at gestational age and you're looking at the blood pressure, because that's going to tell you what they are as far as, okay, you can rule out chronic, you can rule out gestational because you also have proteinuria. Okay, so the correct answer for this is going to be B, okay, because you have a patient that's 28 weeks, that's over 20 weeks, okay, so that wouldn't be chronic. An 18-week gestation with proteinuria, that's a chronic hypertensive, probably with underlying kidney disease. A 28-year-old with proteinuria and elevated blood pressure, that's going to be preeclampsia. And the last one isn't correct because she's gestational. Okay, she's gestational, but she has a headache and no protein. So the headache may be of significance, okay? And the patient under C is going to get a further workup. We just don't have all the information yet. So that patient may very well be preeclamptic, but the information is not there to determine that. So that's why B is the correct answer. All right, so complications of preeclampsia. So decreased end organ perfusion is a consequence, and it's just because of the cascade of the pathophysiology that occurs with this disease. We talked about a spectrum. It can range from presentation without severe features to catastrophic organ failure of the organs. Most severe complications associated with adverse outcomes include eclampsia. So they actually have an onset of seizure activity. Now be aware, all it takes is an elevated blood pressure for a patient to have a seizure. Okay, so they may be just a chronic or a gestational, okay, and not have anything else. But now that they're seizing, this puts them in a whole different category of eclampsia. Abruptoplacenta, okay, placental abruption, hemorrhage or DIC, acute renal failure, hepatic rupture or hematoma of the liver. And if you have severely elevated liver enzymes, these patients can actually rupture their liver, okay? And I've seen this. I've seen patients with liver enzymes in the thousands, okay? So it does happen. Cerebral vascular accident, especially if your patient is seizing. You always want to stick their head in an MRI and see what's going on, because sometimes they have residual effects after a seizure and sometimes they may have had a stroke, especially those patients with blood pressures in severe range, that 160/110 range or higher. Pulmonary edema, hypertensive cardiomyopathy, and of course death. Okay, so preeclampsia with severe features. Okay, so this is going to be differentiated from preeclampsia in that the patient has a systolic blood pressure of greater than or equal to 160 or diastolic greater than or equal to 110 on 2 occasions at least 4 hours apart. Now, if you have a patient with severe range blood pressure like this, you are not going to wait 4 hours to give them a diagnosis of this. You're going to be checking that blood pressure again within 15 minutes, okay? Because you need to treat this blood pressure. That is your number one top priority if you have a patient presenting with blood pressures in this range. Okay, you are not going to wait because they are in stroke range. Okay, so you must notify the provider if you're detecting a blood pressure this high, and then you need to be administering antihypertensive medications. And that's going to be in the form of IV labetalol or hydralazine or PO nifedipine. Okay, visual disturbances. CNS disturbances including altered level of consciousness, irritability, restlessness, or apprehension. And I can tell you this is a really bad sign. Okay, your patient's presenting this way, they have severely elevated blood pressures. 9 times out of 10, they're going to have a seizure or something bad is going to happen. Severe persistent epigastric or right upper quadrant pain or pain unresponsive to pain meds. Remember your liver enzymes, okay? That's why they're having epigastric pain more than likely, because they have liver involvement. Renal insufficiency defined as doubling of serum creatinine greater than 1.1 milligrams per deciliter. Oliguria, so urine output less than 30 mLs per hour on 2 consecutive hours. Okay, now if your patient has oliguria, your patient is really sick. Okay, and this really goes for any patient you take care of, especially patients in critical care. You know this is a really bad sign if they're not making urine. Thrombocytopenia and or elevated AST/ALT and pulmonary edema. So the goals of care are to ensure maternal safety and formulate a plan of delivery. As I said, delivery is a cure. Now, it doesn't mean once the patients deliver, they're going to instantly get better. We have patients that exacerbate their lab values, become very, very high postpartum, and it takes time for them to go down. So they're not out of the woods postpartum. Okay, so we have to watch these patients. Management is based on the severity of delivery, okay? So the more severe this patient is, the more quickly they're going to be delivered. And it doesn't matter what the gestational age is, because remember, we have to save the mom, okay? Mom is in serious trouble when she develops this condition, okay? They may be managed in outpatient monitoring, their own blood pressure and serial labs. And this is really true in the case where they just have an elevated blood pressure and they maybe are spilling a little bit of protein, but all their other labs are normal. Otherwise, these patients are going to be admitted and managed in the hospital until they deliver. Delivery of fetus is a cure regardless of gestational age, but we try to keep them pregnant to get more fetal maturity. Bed rest has been shown to be effective in lowering blood pressures. So that's a lot of times why we admit these patients and manage them in the hospital setting, because we know that they're not going to be up, going to the mall or whatever they're doing, because it's going to make their blood pressure worse. Antenatal steroids are given, betamethasone IM times 2 doses 24 hours apart if the baby is less than 36 weeks gestation. Okay, because remember, we can now give steroids up to 36 weeks. And provided that the mom isn't sick enough to need to be delivered right away and we have time to give betamethasone, we will. Delivery recommended 37 weeks. Again, you need to know that. Okay, 37 weeks is the cutoff. Many times they get delivered earlier, and it's just because the mom develops bad labs or the blood pressure is just unmanageable with medication. Biweekly NSTs beginning at 28 weeks and serial growth ultrasounds. So management of preeclampsia with severe features, and I have that in caps, delivery, okay? So route of delivery depends on severity of disease and status of the cervix. So if we're talking about a primogravida and she's got a cervix that's very unfavorable, like a rock, not dilated, not effaced, any of that, she's going to be a C-section, okay? Because she's sick enough that we need to get her delivered. Initiate antihypertensive protocol for blood pressure and severe range. IV labetalol, hydralazine, or oral nifedipine. Seizure precautions. And we're going to initiate mag sulfate, 4 or 6 gram load followed by 2 grams per hour. Now this is to prevent seizure, okay? So that is the sole purpose of giving magnesium sulfate infusion in light of preeclampsia. Another reason we may give it too, we can kind of kill 2 birds with 1 stone here, is under 32 weeks, these preemies benefit tremendously for neuroprotection from mag sulfate infusion. So these patients are often going to receive that. So we need to do the education of which side effects that we're looking for, and also be aware of adverse effects of magnesium toxicity. Okay, and then these patients mainly go into respiratory failure if they're toxic. Okay, so keep that in mind. Okay, so mag sulfate, more on this. It is the anticonvulsant agent of choice, and you're going to need to know this for your exams. The antidote is calcium gluconate or calcium chloride. Should be available at the bedside, because if they get in that mag toxic Arena, we want to give the calcium gluconate to reverse it. They require close monitoring of vital signs. High alert med requiring double sign off by 2 RNs. Severe and hanging mag sulfate infusion, it requires 2 nurses. Overdose can lead to respiratory failure, we mentioned earlier. So we're monitoring blood pressure, respirations, level of consciousness, DTRs, urine output, and magnesium levels. Okay, now it's going to inadvertently lower the blood pressure, but just remember it's not given for this reason. Okay, it's given for seizure prevention, seizure precaution. So respirations is where you're going to see a change. You're also going to see your DTRs deteriorate with mag toxicity. Okay, we measure urine output because these patients have the capacity to go into pulmonary edema. Okay, so we're monitoring intake and output as well. We don't want to be giving these patients gallons of fluids because it's going to fill up their lungs. So we're watching all of those things. Okay, so another question. Patients receiving mag sulfate infusion at 2 grams per hour for preeclampsia. Which of the following patient requires immediate attention from the RN? A, the patient complains of a headache, blurred vision and dizziness. Vital signs are blood pressure 152/90, heart rate 80, respiratory rate 20, DTRs 2+, and no clonus. B, the patient complains of dizziness and blurred vision. Vital signs are blood pressure 158/97, heart rate 88, respiratory rate 18, DTRs 3+, and no clonus. Or C, the patient complains of dizziness and blurred vision. Vital signs are blood pressure 148/80, heart rate 60, respiratory rate 14, DTR 0, and no clonus. So I'll give you guys a second to think about it before I give you the answer. Okay, and the answer is C. And you're looking at your respiratory rate and your absent DTRs. Okay, so dizziness and blurred vision is a very common side effect of magnesium sulfate infusion. And your patient is going to be at a critical level of magnesium, but the key is they have to be therapeutic. Usually at normal mag level, they're subtherapeutic. So that's why we have to give them the bolus. We have to get them to that therapeutic range. So it's going to do what we want it to do. Okay, decrease CNS irritability in light of an eclamptic seizure. So that's why we want our mag level to be anywhere usually between 5 and 8. Okay, and it is a critical value. So the lab will be calling you and saying your patient has a critical mag. Well, we want it there. And so what we're looking for is these signs of mag toxicity. That's how we know the patient's getting too much. Okay, how are they responding? That's why it's super important that you assess your patient and you really watch these patients that are on these infusions. Here's just a chart for you showing kind of an algorithm of severe preeclampsia, kind of what we do, the management, depending on what's going on with the patient. And again, we're giving steroids over up to 36 weeks. Okay, so eclampsia. This is actually the onset of coma or seizure in women with preeclampsia. They usually have no history of previous pathology, so they don't have history of any kind of seizure disorder. Approximately 1/3 of these women may occur after delivery, and we talked about postpartum, and they're not really out of the woods. So the premonitory signs: persistent headache, blurred vision, epigastric pain, right upper quadrant pain, altered mental status, somewhat this elevated blood pressure. And I told you, I had a patient that happened. She just had a slightly elevated blood pressure and she had a seizure. Okay, so it can happen. So you kind of have to be on the lookout for any of these patients. And they can turn the corner on you really quickly. So they could go from being stable, and then the next thing you know, they're seizing and, bad things are happening. One thing about magnesium I wanted to mention too is that they're usually on the infusion for 24 hours postpartum, okay, because they have that high chance of seizing postpartum. So interventions include maintain airway, call for help, record the seizure activity. Their side rails should be raised and padded, monitor blood pressure, fetal status, uterine status. Now, you're going to usually see the fetus have a big prolonged deceleration. If you remember from the fetal monitoring lecture, this is where it goes down and it stays down for at least 2 minutes, but less than 10 minutes. That's a prolonged decel. Typically, when a woman seizes, she's not breathing. So that's expected, okay? But once the seizure is over, it's expected to come back up. And if it doesn't, that's a situation where we need to get the baby out emergently. Now, otherwise, we are not going to crash these patients in the midst of a seizure. We want her to recover, we want the baby to recover. And that's really the goal when we deliver these patients. We never want to deliver them when they're not stable. Okay, we always want to try to stabilize them first. Your uterine status, you're going to see an abruption type pattern. We talked about elevated blood pressures. Usually when they're having increased seizure activity, you're going to see those frequent low amplitude contractions resembling a abruption pattern. And these patients often, if they're in labor, will go very quickly. We also want to provide a quiet environment. Talked about the decelerations, rapid progression in labor, and we don't want to crash them until we stabilize the mom. So HELLP syndrome is a subtype of preeclampsia. Okay, it's different disease process, and we differentiate it from preeclampsia with severe features, and we'll talk about that coming up. So they actually have hemolysis, elevated liver enzymes, and low platelets. And so that's why they call it HELLP, because they have all this. Variant of severe preeclampsia, but a separate disease process. And this is typically where they go into endothelial damage, and then they deteriorate rapidly when they're in HELLP syndrome. And it's typically a rapid onset. Okay, they present with vague symptoms. Very rarely does a woman ever evolve into HELLP. Okay, they usually hit the door like severely ill. Okay, really high blood pressures, really bad labs, and it's a quick onset. They may have been fine a few days ago. Their blood pressure may have been normal in the office 3 days ago, and now they have this severe development of high blood pressure and these symptoms, and also really, usually really bad lab values. Okay, so generally does develop in the 3rd trimester. Again, that's good news for delivery of the baby. And it may develop within 48 hours after delivery. It affects 5 to 20% of preeclamptic women. The rate of preterm birth with HELLP, as you can see, it's approximately 70%, with 15 of those occurring prior to the 28th week. So usually women with really severe hypertensive disorder, if they develop it, they're developing it around 26 to 28, 29 weeks. It's usually HELLP syndrome that they have, okay? Where the other types, usually they're developing them after the 3rd trimester, and it's kind of more of a mild type of case. So pathophysiology, I kind of discussed this a little bit, but they do have those arterial or vasospasms, endothelial cell dysfunction, injury with fibrin deposits, and adherence of platelets in the blood vessels. So this is the worst part of it as far as the patho. It does activate the clotting cascade due to fibrin deposits. They have RBC hemolysis, damaging erythrocytes, and this is evident on peripheral smear. That's really how we diagnose hemolysis. Endothelial damage and fibrin deposits in the liver leads to impaired liver function, and then hemorrhagic necrosis. And a lot of times that's where these women, their clotting factors are consumed, so it affects the whole clotting cascade, including fibrin, fibrinogen, all of those. Okay, so this is where they get really sick and end up in ICU. So it's a very non-specific clinical presentation, and it's like usually when you work labor and delivery long enough and someone presents to your unit and they have these complaints, you kind of usually know you're going to get them in the room, hook them up to the blood pressure machine, it's going to be high. They're probably going to be in HELLP syndrome because you can tell just how they look. They don't look well. Now, when you have some of preeclampsia, they may feel fine, but these patients with HELLP syndrome do not. And usually they're very vague complaints, malaise, epigastric pain, right upper quadrant abdominal pain. Sometimes it's just nausea and vomiting. Like they don't really have specific area of pain, but they're just nauseated and vomiting. Headache, vague symptoms. And then you may see bruising or hematuria and DIC, signs of that if they are if they have thrombocytopenia. Okay, so how do we differentiate? So may have one or all the features of HELLP. Okay, that's usually going to be your severe preeclampsia. Okay, so they may just have elevated liver enzymes, but everything else is normal. With HELLP syndrome, they usually have the whole shebang. Okay, and then we talked about abnormal peripheral smear. They'll have an elevated LDH because, again, with this condition, we're going to be running an LDH level. Decreasing hematocrit, bilirubin, so bilirubin greater than 1.2, okay, and decreasing hematocrit just because they're consuming all their clotting factors, and usually they're getting a little bit anemic. Elevated liver enzymes, so AST, ALT, they're twice the upper normal limit, and as I mentioned earlier, their LDH is going to be greater than 600 international units per liter. Malaise, viral-like symptoms, they may just feel like they have the flu, and that's what they may tell you. And then you take their blood pressure, it's really high. Right upper right quadrant pain or epigastric pain, thrombocytopenia due to platelet consumption, and then again may lead to DIC, so we're checking coags, fibrinogen, PT, PTT, bleeding, oozing from unusual sites. This is going to be like their IV site, their Foley site. Their gums might be bleeding. They may have epistaxis or bloody nose. Low platelets, less than 100K. Severe, less than 50. Elevated LDH associated with poor maternal and fetal outcomes. Okay, so this is just an algorithm kind of showing you the different types of hypertensive disorders, okay, and what you may see. It's just a good little chart to review. Preeclampsia and postpartum period. So we talked a little bit about this, how they're not out of the woods. In fact, a third of women we'll see is postpartum. That's why we keep them on that 24 hours of MAG. So we're checking vital signs, DTR, level of consciousness, urine output, especially on my MAG sulfate. But you're also wanting to watch it for that factor of the creatinine, okay, that could be in kidney failure. 30% of cases of eclampsia and HELLP occur postpartum. Many times disease exacerbates postpartum, so their labs may look okay. They may have high blood pressure, and we deliver them at 37 weeks. Then the next day, we're checking labs, and lo and behold, their liver enzymes are high. Okay, so we're watching this stuff. Usually the patient is not going to be discharged home until those labs improve, because they're going to get bad, they're going to peak out, and then they're going to improve. Okay, so that's kind of what we're looking for. And then some women, they don't like having to stay in the hospital, but we have to tell them you're sick. They may not feel bad, okay, they may feel fine, but they have to understand that the labs are telling us they're sick and they need to stay, and we need to see that they're getting better. Because they could go home and have a seizure or a stroke, and then they're going to end up right back in the hospital. So we have to do that education. These women a lot of times don't tolerate excessive blood loss, so we want to watch them for hemorrhage. So future of healthcare, they have a 7-fold increased risk of developing preeclampsia or eclampsia in a future pregnancy. And again, the sicker they are, the more likely this is going to happen. Increased risk of adverse perinatal outcomes. So this is a little bit of a case study just to kind of help you think about a patient. A 36-year-old woman is pregnant with her first child. She presents to labor and delivery at 28 weeks with complaint of headache for 3 days and is noted to have a blood pressure of 150/94. Her pregnancy has been uncomplicated and she has no history of hypertension. She reports feeling very puffy. What factors noted indicate a risk of preeclampsia? What additional tests can be ordered for the diagnosis of preeclampsia? And what treatments can be expected for the management of preeclampsia? So a patient like this, risk factors, okay, she's 36, she's older, this is her first baby, prima gravida, okay, she's at 28 weeks, she already has a headache, okay, and a blood pressure 150/94, okay, so we know she's preeclamptic, or she may just have gestational hypertension until we run labs. Okay, we don't really know until we run labs. So the headache may be or may not be related to it. Most likely it is if her blood pressure is elevated. She's reporting feeling puffy. Now, one thing I do want to say about edema, the higher up the edema and the swelling, the worse it is. And usually if they have severely high blood pressures or they have abnormal lab values and they're puffy, especially in their hands and their face, this is way more concerning than them just having peripheral edema in their lower extremities. So keep that in mind. They're usually going to have this full-on puffy edematous look, okay? They don't usually look well. Okay, so we're going to order CBC, CMP, urinalysis, uric acid, okay? So we're going to be looking at those things. We're going to be looking at platelets and the CBC, hemoglobin, hematocrit. CMP, we're going to be looking at AST, ALT, BUN, and creatinine. Okay, bilirubin even, because that's going to be in there too. So we're going to be looking at all those things in the CMP. And you want to make sure you get a CMP. Don't get a basic metabolic panel because it's not going to give you the liver enzymes. Okay, so you need those. Uric acid, if I didn't say that, but you're going to be looking at creatine-creatinine ratio. And if she's fairly stable, this patient would be one that would be admitted and should be on a 24-hour urine collection for protein and creatinine clearance. What treatment can be expected for the management of preeclampsia? Well, that's all going to be dependent on her labs. Okay, if her labs are she's found to be in severe range, with headache, visual changes, epigastric pain, this is going to put her in with severe features. And if she's in severe features, it's all going to be dependent on her other labs. But as long as her blood pressure doesn't exceed severe range and we're able to control it, we may try to buy a little time with this particular patient because she's 28 weeks. So she is a candidate for antenatal steroids. So we want to try to get that in. But this lady will most definitely get steroids if we can get that in. All right, there's some references for you. And if you have any questions, please email me in Canvas. Thank you.